In 2022, the European Journal of Radiology published a paper by Dr. Laszlo Tabar and his colleagues that proposed a significant shift in breast oncology. Modern mammography screening has successfully reduced mortality for acinar adenocarcinoma, which accounts for the majority of all breast cancers. However, patient outcomes for cancers originating in the major lactiferous ducts haven't followed this trend. For these specific cases, the expected survival benefits of regular screening are not being met. The author suggests the issue lies in classification. Current medical practice groups these major duct cancers under the term ductal carcinoma in situ, or DCIS. The term in situ implies a non-invasive condition confined within existing anatomical borders. This terminology fails to account for the physical behavior of this specific breast cancer subtype. Using protocols designed for a static, localized condition to manage an actively invasive pathology results in inadequate surgical margins and insufficient systemic treatment. This clinical galactogram and circular subgross histopathology establish the baseline spatial architecture of a normal breast lobe, showing the tree-like structure of healthy lactiferous ducts and their terminal lobular units. The healthy branching system resembles a deciduous tree, where the ducts act as branches that narrow as they reach the functional lobules. The resting major lactiferous duct has pleated walls, much like a saguaro cactus, providing mechanical flexibility to expand. This flexibility allows for neoductgenesis, where cancer cells force the tissue to build complex, three-dimensional duct-like structures to house the growing tumor. Standard thin-section biopsies produce two-dimensional microscopic slices. These are unable to capture a sprawling, three-dimensional expansion, often leading pathologists to see cells contained within a 2D boundary and conclude the cancer is in situ. Neoductgenesis allows ductal adenocarcinoma of the breast, or DAB, to manufacture its own invasive pathways, moving independently of the breast's pre-existing anatomy. Neoductgenesis leaves distinct architectural footprints on imaging. Fragmented, casting-type calcifications, seen as white snakeskin-like fragments on this microfocus radiograph, reliably signal this malignancy. These fragments correlate to tumor cores. Histological cross-sections reveal black amorphous calcific deposits directly inside the newly formed ducts. This occurs when grade 3 cancer cells multiply rapidly, creating a solid mass that distends the walls of the major lactiferous ducts. The rate of proliferation often exceeds the local blood supply. The center of the tumor eventually undergoes intraluminal necrosis due to the lack of oxygen and nutrients. As the dead cellular matter decays inside the duct, it hardens into dense, solid calcifications that effectively take the shape of the interior space. The fragmented calcifications visible on a mammogram are fossilized casts of necrotic tumor cores, mapping the pathways of the newly forged ducts. Grade 1 and 2 tumors utilize growth patterns that secrete proteinaceous fluid. The top panel illustrates the resulting skipping stone distribution within the breast lobe. This fluid calcifies inside the neoducts, matching the microscopic cribriform gaps seen in the thick section below. Fluid secretion creates a fourth biomarker, a string of pearls presentation, seen as a line of rounded microcalcifications trailing through these mammograms. These pearls correspond to large Samoma body-like calcifications formed within the major ducts, visible in the stained histological sections. Both necrotic decay and hardening protein fluid create physical, three-dimensional casts of the invasive neoduct network. In the fifth subgroup, patients present clinically with bloody or serous nipple discharge. Because the fluid hasn't calcified, the tumor is invisible on standard mammograms. Advanced modalities are necessary. An MRI shows extensive non-mass enhancement, and a galactogram reveals tiny filling defects. These diagnostic images show a fluid-secreting micropapillary cancer proliferation growing steadily from the nipple toward the chest wall. A clear standard mammogram in a patient experiencing discharge points toward a non-calcified neoductgenesis that requires immediate MRI mapping. The final biomarker is a palpable mass presenting as architectural distortion. This MLO projection lacks calcifications, but low-power histology reveals distended, tumor-filled neoducts clumping together. High-power views confirm this cellular clumping is accompanied by heavy lymphocytic infiltration and severe desmoplastic reaction. As thousands of new ducts expand, They physically pull and tether the normal collagen framework of the breast. The geometric distortion visible on an X-ray is the macroscopic evidence of an expanding, uncalcified micronetwork displacing the surrounding tissue. The extensive geographic territory this disease can occupy contradicts the in situ label. These mammogram projections show a wide field of microcalcifications covering a large portion of the breast. This disease can form a contiguous column stretching from the chest wall to the epidermis, causing the clinical changes associated with Paget's disease. Despite the size of these tumors, important immunochemical biomarkers are rarely tested on the DAB tissue. Pathologists often omit these tests because the administrative label of DCIS suggests a non-invasive condition that does not require such deep analysis. Treating an active malignancy as in situ leads to residual disease and significantly higher rates of local recurrence and systemic progression. In this case, dense mammograms appear clear, but an MRI reveals a tumor mass that was mammographically occult. Large format, thick section histology reveals the true nature of the mass, a poorly differentiated triple-negative invasive neoductgenesis. Detecting this disease requires clinical adaptation. Radiologists must systematically utilize image enlargement and MRI to map the biomarkers of DAB. Standard core biopsies must be interpreted alongside large format histopathology to capture the three-dimensional invasiveness of the tumor network. True precision oncology requires the medical community to move past the obsolete term DCIS and recognize ductal adenocarcinoma of the breast as an actively invasive malignancy.